Hi, everyone from Room Now. This is Michelle Petri with my fourth and final update from the ACR Convergence meeting. I hope you've had a chance to view the original three. Today, I'm going to do something a little bit different. You all know I'm a clinician and how important I think updating on clinical studies is to our practice. But today, I want to get you excited about some basic science improvements. In particular, I want to review the urine proteome and what do these advances mean to us. So let's start with some context. You know, right now in lupus nephritis, we follow proteinuria, and our goal is a complete renal response, getting our patients to below 500 milligrams. But now I have to shake your faith in this clinical outcome because, in fact, proteinuria doesn't always indicate renal activity. And it can go the other way. Resolution of proteinuria doesn't mean that the renal activity is necessarily gone. So in fact, when there's persistent histological activity, even if the proteinuria has reached the outcome, that patient's still very likely to have a flare. So I've never met a kidney biopsy I didn't like, because they usually end up changing the treatment. But let's be honest, the patient doesn't like them, and that's why we don't do them frequently. So this is where the Accelerated Medicines Partnership has taken such a leading role. And remember, this is all centered around doing the kidney biopsy and then doing single-cell RNA transcriptomics. But the Hopkins group has led the urine proteomic arm. So this is how AMP was organized, the kidney biopsy, and then a urine specimen at week 0, 12, 24, and 52. These were then subjected to a urine proteome screen called Kiloplex that can actually quantitate 1,200 different urine proteins. So Andrea Fava from our group has presented 3 key findings at ACR Convergence. And the first is to bring forward urinary CD163 as a urine proteome marker of proliferative lupus nephritis. Now, as clinicians, we're going to have to get used to these plots. They're called volcano plots. It's how big data can be presented to us. And what you see circled in red is CD163, which comes from the M2 macrophage. That's considered a tissue healing macrophage. And you can see that the results from the first AMP cohort on the left were reproduced in the second cohort on the right. You see the big arrow pointing to CD163. But in addition, Brad Rovin's group had already brought up the potential importance of CD163 as a urine proteome biomarker. You can see that in people who respond, CD163 also goes down. But that's just the beginning of the story. So another marker in the urine proteome is interleukin 16. Now you're used to this, you know volcano plots, and you can see both in the original cohort and the validation cohort, interleukin 16 there at the top. And nobody knew about interleukin 16 in lupus nephritis until this urine proteome screen was done. Now, not only does interleukin 16 go down in the responders, but this one is independent of proteinuria. So it might be particularly useful in those patients in whom we find that the proteinuria is normalized. We still want to ask the question, is there still renal histologic activity? Turned out it was the most highly expressed cytokine. And how could we have missed it all these years? This is the excitement of basic science discovery. And what is it? It's a proinflammatory chemokine. It's the ligand of CD4. And so it's one of the reasons that all the other inflammatory cells are coming into the kidney. But now there's a third one, neutrophils. Now, back when I was in training, we were told lupus was a lymphocyte disease. Of course, everybody was wrong. It's also a neutrophil disease. And here you see circled all sorts of neutrophil markers in the urine. Incredible how many there are. And it turns out this neutrophil signature is associated with histologic activity. And here's the proof it's all coming from the kidney. You can see all these neutrophils. So it means that we just can't have anti-lymphocyte drugs, right, or therapies. We're going to have to go after neutrophils too. So I hope that in this number 4 update, I've gotten you excited that basic science is going to catch up and help us in making treatment decisions in our patients. Thank you all from Room Now.